Good morning to everyone and welcome to the fifth and final session of the second webinar series of the WHO Clinical Management Guidelines. But this morning we are joined with colleagues. We are joined by colleagues from the UNICEF Philippines and UNFPA Philippines, as well as the Department of Health. The issue for discussion today would be pregnancy, women's health, and the care of children with COVID-19 and during this COVID-19 pandemic. So I'd like to introduce to you the speakers. My name is Dr. Albert Domingo. I'm moderating the whole session. I'm from WHO Philippines. Together with me now are Dr. Gary Kuniyoshi from the WHO Regional Office in the Western Pacific, Dr. Mariela Castillo, who is joining us from UNICEF Philippines. She is a pediatrician by training and profession. Dr. Joseph Michael or Mike Singh of UNFPA Philippines, the Chief of Health of the UNFPA Philippines office, Dr. Anthony Calibo from the Department of Health Disease Prevention and Control Bureau. He is also a pediatrician here in the Philippines. And to join us later would be Ms. Zenny Residoro, also from the Department of Health Disease Prevention and Control Bureau, a nurse by profession who is handling the Women's Health Program of the Department of Health. We now have 153 participants on Zoom. We are also live on YouTube. So just to remind everyone, our format is we begin with a presentation of around 30 minutes. It will be delivered today by Dr. Castillo, followed by a Q&A portion where all of the panelists will join us. For those who have questions, you can always type in your questions using the Q&A feature down at the bottom of the app. There is a Q&A button in Zoom, both in the laptop and in the mobile versions. Then when you open it, there's a box that will pop up. You can type in rather your questions. If you see a question from another participant, which is interesting and that you'd like to join in, you can click on the thumbs up or the like button, which will allow the question to be upvoted so that the moderator will be seeing it first on the list. So having said that, I will turn over now. We are now at 184 and still climbing number of participants. Dr. Yala Castillo, over to you for your presentation.
Thank you, Albert, and good morning, everyone, and good morning to my co-panelists, the other resource persons. We are here this morning to share a summary of the available evidence on COVID-19 and mothers and infants. So let me share my screen and go on slideshow. Albert, please give me feedback.
We're seeing the editing version probably in a few seconds.
Yeah, so we apologize. There's a bit of a delay in the slideshow, but this is what we will be talking about briefly this morning: caring for women with COVID-19 in the health facility setting during pregnancy, childbirth, postnatal period, and breastfeeding.
Is it on slideshow on your end, Doc Ella?
Yes.
Okay, not yet. Maybe I'm gonna try to also, hold on. Still not showing. Okay, what we're gonna do is, maybe Doc Yala, while I try to intervene, I might try to show it from my end. Could you unshare? Could you please give us your insights in general first on what you think of the care of children, and then while you're doing that, I'll bring up the slides.
Okay, I've stopped sharing. Actually, we appreciate this forum, Albert, because it will bring many clinicians up to date. It puts all together in one. It puts together in one place, sort of a synthesis of where the evidence is, especially now that we're, 6 months after the outbreak has started, and there's been clinical experience as well as publications on COVID-19 in relation to pregnancy, delivery, and the care of newborns.
Are you seeing
So
it on your side already, Doc?
yes, I see the screen. I see the screen. So maybe you'll just
Just let
have
me
to
know.
help me
Yeah.
along. Yeah.
Sure, sure.
Okay. We can move. So for this morning, next slide. We hope that we will be able to share with you what are the considerations in caring for women with suspect, probable, or confirmed COVID-19 infection during pregnancy, in the intrapartum period, postnatally, and after pregnancy loss. Encourage, enable, and support breastfeeding for infants of mothers, even though they have COVID-19 illness. And then lastly, how to support the needs of pregnant women, mothers with probable, suspect, or confirmed COVID-19 status and their infants. Next slide. We'll, okay, there's on the chat, Paul is saying there are no slides. They don't see slides.
Are you seeing it on your end, Doc Ella?
Yeah, I see it.
Okay. Um, can another panelist please, Gary, are you seeing the slides on your end?
I can see the slides.
Okay.
Now they're
Sir,
saying they can see the slides fine.
See the slides
Mark Benjamin is
okay,
saying
okay.
they can see the
All
slides.
right.
All
It
right.
might be a slight delay. Please
Okay.
proceed, Doc Ella.
Thank you. So we'll start off with the key messages. Thank you for your feedback, everyone on the chat. Okay, we'll start off with the key messages. So at this point in time, there's no evidence that pregnant and postpartum women with COVID-19 infection present with different signs and symptoms or are at higher risk of severe illness if they do get COVID-19. At the present time, there's no clear evidence of mother to child transmission of COVID-19. And pregnant women with suspect, probable, or confirmed COVID-19 infection, even if they're in isolation, should have access to woman centered, respectful, skilled care while applying the necessary infection prevention and control or IPC measures. Next. And the last key message for this morning is that regardless of the COVID-19 status of the mother and the baby, they should remain together, breastfeed, practice skin to skin contact, kangaroo mother care for the low birth weight babies and small babies, and room in day and night while applying necessary IPC measures. We can move, Albert. We'll start off with the considerations for women, for pregnant women. At this time, there's limited data on clinical presentation of COVID-19 infection during and after pregnancy that suggests that the limited data on the clinical presentation suggests that pregnant and postpartum women are not at higher risk of infection compared to non-pregnant women or adults of reproductive age. So pregnancy in and of itself does not seem to be associated with a higher risk of COVID-19 infection. Also, that pregnant and postpartum women present with similar signs and symptoms and are not at higher risk of severe illness should they get COVID-19. Next. When during the clinical assessment, the suspicion of whether a woman has COVID-19 infection should take into account the changes that occur in pregnancy. Because of the non-specificity of the presentations of COVID-19 illness, symptoms that are due to the physiologic adaptations of pregnancy or adverse pregnancy events such as dyspnea, fever, gastrointestinal symptoms, fatigue they may overlap with COVID-19 symptoms. So they need to be put together in the clinical assessment. And what remains is the already the well-known fact that it's persons with comorbidities such as cardiovascular disease and diabetes mellitus that have increased risk of severe disease and mortality. In this cohort of patients with comorbidities in COVID-19, they may present with mild symptoms, but they have a higher risk of deterioration. Next slide. At present, it's also important to know that there's limited evidence for mother-to-child transmission or increased adverse pregnancy or neonatal outcomes. Okay? The evidence that we have to date is mainly reported from infections that occur in the third trimester of pregnancy. Swabs or samples from amniotic fluid, cord blood, vaginal discharge, neonatal throat swabs, and breast milk have all yielded negative results. The few newborns who have been confirmed to have early onset COVID-19 illness experienced mild illness. While there are anecdotal reports of premature rupture of membranes, fetal distress, and preterm birth, the association with COVID-19 infection of these adverse outcomes have not been established. Next slide. When it comes to caring for women during pregnancy, childbirth, and postnatally, the standards should not change. So pregnant women with COVID-19 infection, even if they are in isolation, should have access to quality, woman-centered, and respectful, skilled care. What does it mean to have quality, woman-centered, and respectful, skilled care? It means a woman should be treated with dignity, privacy, and respecting their confidentiality, ensuring that they're not harmed or mistreated during treatment. And also, very important, is enabling informed choice, allowing the woman and the family to make informed decisions about the care that they will receive. Women-centered, respectful, skilled care also includes the benefit from a multidisciplinary team if the case calls for it, having access to facilities with readiness to care for complicated maternal and neonatal conditions, and also having the benefit of mental health and psychosocial support. Next slide. It is known that there are asymptomatic presentations of COVID-19. And in that case, asymptomatic presentation of COVID-19 is also possible in pregnant and recently pregnant women. So it's important to also be aware of the history of contact or being a close contact and all the protocols in country that go with it. So at this point, there's no evidence that pregnant women present with increased risk of severe illness or fetal compromise. And all pregnant women with or recovering from COVID-19 illness should be provided with counseling and information related to the potential risk of adverse pregnancy outcomes. Next, Albert. Pregnant and recently pregnant women who have recovered from COVID-19 should be enabled and encouraged to attend their routine sexual and reproductive health care. And additional care should be provided if there are any complications. Also, women's choices and rights to sexual and reproductive health care should be respected regardless of COVID-19 status. And that also includes access to contraception to the full extent of the law. Next. What are the considerations during the intrapartum period? And you will notice that many of the recommendations of the WHO are already embodied in the Philippine EINC Essential Intrapartum and Newborn Care Guidelines. This includes, so whether they have COVID-19 or not, this includes having a companion of choice during childbirth, but with consideration of the appropriate IPC measures for the companion of choice and for limiting or restricting the movement of that companion in the healthcare facility. It's providing adequate pain relief strategies, the allowing the woman to walk around, the adoption of mobility and an upright position where possible, and receiving continuity of care with the appropriate primary provider, that seamless transition from the antenatal, intrapartum, and postnatal care. Next slide. Next, please. And then also the mode of birth, the mode of delivery, whether it's abdominal or vaginal delivery, it should be based strictly on obstetric indications and not on whether the woman has COVID-19 or not. So the WHO recommends that medical interventions, including cesarean section, induction of labor, and episiotomy, should be based on obstetric indications. What about a woman who is in preterm labor? WHO recommends that antenatal corticosteroid therapy for women at risk of preterm birth, that is from 24 to 34 weeks of gestation, when there is no clinical evidence of maternal infection and adequate childbirth and newborn care is available, then antenatal corticosteroid therapy is recommended. In cases where a woman presents in preterm labor with mild COVID-19, the balance of benefits and harms for the administration of the steroid for the woman and the preterm newborn should be discussed. And this assessment, of course, may vary depending on the woman's clinical condition, her wishes, and that of her family, and the availability of the appropriate healthcare resources in that situation. Next, please. So maternal and newborn services in the context of COVID-19 should sustain the routine maternal and newborn care and the management of complications. That includes, of course, establishing triage, early recognition, and source control of suspected, probable, and confirmed COVID-19 infected women. And the PPE, the appropriate personal protective equipment, and IPC measures should be adjusted accordingly based on the national protocols or standards. In all circumstances, ensure that there's appropriate physical environment with adequate water, sanitation, and energy supplies, medicine supplies, and equipment to cope with both the COVID-19 situation as well in delivering routine maternal and newborn care. Next. We now move to considerations on what are the available evidence and recommendations on COVID-19 infection and breastfeeding and the care of newborns. The evidence is very strong that breastfeeding protects against child morbidity and death, especially against infectious diseases. And so the evidence is solid that non-breastfed children incur morbidities that also place them at higher risk of lifelong ill health, not just from infections, but also from non-communicable diseases. The evidence is also strong that breastfeeding has protective effects on the mother. It protects women against breast cancer and improves birth spacing, protecting women specifically from ovarian cancer and even type 2 diabetes. Also, practitioners and policymakers should remember that the virus that causes COVID-19, SARS coronavirus 2, go back, is not documented to be transmitted through breast milk. So it is safe to breastfeed, and continuing breastfeeding is life-saving. So none of the evidence has changed about the benefits of breastfeeding. Next. So when we care for mothers with COVID-19 who have delivered, health workers should provide breastfeeding advice and support that mothers and infants not be separated to allow skin-to-skin care after birth and breastfeeding. According to our EINC protocol, breastfeeding should be initiated around 1 to 2 hours of birth or when the newborn shows signs of readiness to breastfeed. So, so the protocol must be continued as before, no? So disruptions to breastfeeding should be minimized, and mothers should be enabled to breastfeed for as often and for as long as she wishes. So, and this will happen in a rooming in situation. Next, Albert. And in line with our infant and young child feeding protocol, exclusive breastfeeding should continue for 6 months with timely introduction of complementary feeding that is adequate, safe, and properly prepared and properly fed at the age of 6 months. And breastfeeding should be continued up to 2 years and beyond. Next. So even if a woman has COVID-19 infection, WHO recommends that all women should be supported to breastfeed. There will be situations when a mother right after giving birth may be unable to breastfeed because of anesthesia or is medically unstable, or the infant himself or herself is the one that's unstable and needs to be admitted to the neonatal ICU. But mothers unable to breastfeed immediately after delivery should be supported to breastfeed as soon as they are able to do so. Next. The other evidence-based interventions for newborn care, such as kangaroo mother care, should also be practiced regardless of COVID-19 status. So skin-to-skin contact must be practiced, must be supported, and must be uninterrupted, as well as the practice of kangaroo mother care and rooming in. The additional consideration is the application of the necessary IPC or infection prevention and control measures. Skin-to-skin contact is important. It's part of the 4 core steps of EINC because it's important for not just the establishment of breastfeeding, the initiation of breastfeeding, but also for thermal regulation to reduce neonatal mortality. The appropriate hygiene measures to protect infants of women with COVID-19 during skin-to-skin contact, kangaroo mother care, and rooming in are the same as the IPC measures that are recommended for breastfeeding mothers. Next. It is a well-established fact that the presence or the promotion of infant formula or breast milk substitutes contributes to the lowering of breastfeeding rates. So regardless of COVID-19 status, mothers should be supported to breastfeed by having access to breastfeeding counseling, basic psychosocial support, and practical feeding support. Practical support to enable mothers to breastfeed include the IPC measures, and healthcare professionals should be well versed in the IPC measures that should be practiced. Next. If COVID-19 is suspected or confirmed, the appropriate hygiene measures can still protect the infant or child. So we've established earlier in this lecture that there's no mother-to-child transmission, and neither is SARS-CoV-2 transmitted or present in breast milk. So the protection really remains contact and droplet precautions that include washing hands before and after breastfeeding the child or infant, respiratory hygiene, that is, wearing a medical mask when you have respiratory symptoms, and if a mask is not available, coughing or sneezing into a tissue and then disposing of the tissue immediately and performing hand hygiene, as well as the routine cleaning and disinfecting of high touch or frequently touched surfaces and objects. Next. When a mother who's breastfeeding and has suspected or probable COVID-19 and she happens to cough on her chest, she should be helped to clean her chest before breastfeeding, but she does not need to wash her breasts prior to every breastfeed. Next. In situations when there is a shortage of medical masks, there are still options to continue breastfeeding. First is the respiratory hygiene, sneezing and coughing into a tissue and immediately disposing the tissue, and then performing hand hygiene. No? If alcohol hand rub is available, then alcohol hand rub, otherwise washing with soap and water. At present, the WHO has not evaluated the use of non-medical, the homemade masks, no, the DIY or cloth masks, and its use should be based on risk versus benefits considerations. At present, there's not enough evidence to make recommendations for or against the use of the cloth masks. It is possible that mothers with COVID-19 may develop severe illness or complications that then prevent her from caring for her infant or prevent her from breastfeeding. Then you have other options to consider, to go to continue breastfeeding. Number one is mothers can be supported to express and feed breast milk to her infant with the appropriate infection prevention control measures. Next slide. The next option after breast milk expression would be relactation, or explore the viability of donor human milk or wet nursing until she is well. And breast milk substitutes or infant formula should only be considered a last resort and can only be given if it is safe, feasible, sustainable, and acceptable and available within the mother's cultural context. Next. So in situations where there is a shortage of medical masks, mothers should be encouraged to continue breastfeeding or providing breast milk, regardless of the availability of medical masks, because the benefits of breastfeeding far outweigh the potential risks of transmission of the virus when breastfeeding. Next, please. When mothers are unnecessarily separated from their newborns or their infants, when they're and also when children are separated from their caregivers, there can be severe or even long-lasting mental health effects. So parents or other caregivers who are separated from their children, and as well as children who are separated from their caregivers, should have access to mental health and psychosocial support from trained individuals. All of these are components of quality and respectful care for mothers and their families. I'd like to end with this summary slide on the current evidence and the recommendations from the WHO and UN agencies. First is that there's no evidence that pregnant women present with different signs and symptoms or at higher risk of severe illness from COVID-19. And there is little evidence for mother-to-child transmission as well as COVID-19 transmission through breast milk. Pregnant women with COVID-19, even if they are in isolation, should continue to have access to women-centered, respectful skilled care while applying necessary IPC measures. And regardless of COVID-19 status, mothers and infants should remain together. Mothers should be allowed to breastfeed. They should be allowed to remain in skin-to-skin contact, practice kangaroo mother care, and rooming in day and night while applying the appropriate infection prevention and control measures. That is the last slide. Thank you very much, and we move to the Q&As.
Thank you, Dr. Castillo, for that presentation. So I'm looking now at the panelists in gallery view, and just to refresh, we have with us Dr. Gary Kuniyoshi from the WHO Regional Office for the Western Pacific. You just heard Dr. Yela Castillo from UNICEF Philippines. With us would also be Dr. Michael Singh of UNFPA. And then Dr. Anthony Calibo is joining from the Department of Health Philippines, and Ms. Zeni Risidoro from the DOH is also joining us. So, all right, hold on. Ms. Zeni, can you please stand by? There you go. All right. So, looking at the questions, there is a question and answer button at the bottom. I'm seeing now there are 13 questions. And to all participants, we have just a quick count. I'm looking at the number of participants, 308 participants with us at halfway through the hour. And the way we're going to do this is for the remaining 30 minutes, as the questions come in, if you see a question which you agree with, just click the the like icon, which will upvote the question and bring it closer to the top. Maybe I'll begin a question. I'm seeing here from Anne. What are the key sexual and reproductive health issues that UNFPA is able to monitor during the COVID-19 and the lockdown? At least in the Philippines, we have probably experience from that. Let's ask Dr. Michael Singh, Mike Singh from UNFPA. Sir.
Yes. Thank you, Albert, for that one. Let me share a background on this one. Okay. Can you see the presentation now?
Yes. Please show a slideshow, please.
Can you see it now, Albert?
Yes. Please proceed.
Okay. So UNFPA has been trying to monitor the SRH implications of COVID and the lockdown. And I will be sharing with the group what are the leading issues that we have been trying to monitor. We have been doing this with our implementing partner, the Philippine Society for Responsible Parenthood. So we have a website and attached Facebook pages. In the past 28 days, we have reached around 276,000 people. And the leading issues that we have been monitoring is, one is on family planning. We have received around 135,000 comments queries on family planning and around 19,000 post queries, all about questions on preventing pregnancies. And in the past 28 days, we have more than 50 posts reporting that health centers are closed, meaning to say some women cannot get their scheduled injectable shots, hence some are switching to oral contraceptive pills or resorting to withdrawal methods. Some are reporting too that their hormonal implants cannot be removed or reinserted, hence switching again to oral contraceptive pills and the withdrawal method. Some have reported that there is no resupply of oral contraceptive pills for continuing users. IUD checkups which are scheduled are missed, and many are buying oral contraceptive pills from pharmacies. Now, the issue with those buying from pharmacies is that they pose questions on how they use it. They buy it, but they are not guided on how to properly use the oral contraceptive pills. Now, for pregnancy, this is very alerting. In the past 28 days, we received 30 plus posts on postpartum depression. And one incident of a 19-year-old mother who posted about her postpartum depression issues, and 2 days later, she was reported dead already. All those who have reported on postpartum depression or other mental health issues were linked to all available mental health hotlines at the moment, such as the one of the National Center for Mental Health. Then there are posts also about mothers reporting on vaginal bleeding, but they have difficulty accessing services due to the lack of public transportation. And there are mothers too who doesn't want to have facility-based deliveries because they fear they may get COVID-19 in the health facility. Now, there are also another big issue, which is there are also near-term pregnant women who are stranded because of the community quarantine and cannot go home to the provinces. And some of them too cannot go home to the provinces because there is a lack of public transportation. So this is another issue that I think all of us should look into. And lastly, there are reports too about women consulting on STI signs and symptoms, such as vaginal discharges, itchiness, and foul smell. So that's a summary of the things that we are able to monitor during the time of COVID and during the lockdown. Over to you, Albert.
Thanks, Dr. Mike, for that interesting list of issues that have been monitored by you and FPA. Indeed, the COVID-19 pandemic or outbreak in the Philippines is and elsewhere in the world is presenting with a lot of issues as far as the care pathways are concerned. I'll connect a question coming from Joyce. Maybe this one can be answered by our colleagues from the Department of Health. So Joyce is asking, moving forward, do we have a protocol on the number of face-to-face checkups? And at what age of gestation should this be done? She's asking about pregnant women. I'm seeing Ms. Zeni of DOH. Ms. Residoro, would you want to respond to this question, ma'am? Ms. Zeni? Okay. I hear a child in the background, very apt for our discussion. Ms. Zeni, ma'am, your microphone is on. Please proceed. All right. Maybe while Ms. Zeni is catching with the technical issues, I actually saw her reply in the chat box. She mentioned about Department Circular 2020-0167 of the DOH, and suggesting that prenatal care should continue as much as possible, the continuous provision of essential health services. Dr. Anthony from DOH, maybe since Ms. Zeni can't respond for now, can you also give some comments on this, sir?
Okay, while Ma'am Zeni is going to catch up, I think the department circular issued back then was during the height of the enhanced community quarantine. Even extending to the modified enhanced community quarantine. Now that many areas have been eased up to the general community quarantine, and private clinics and public health facilities have actually started to reopen, I think face-to-face contact is now dependent on the openness of the physicians who will be catering to the needs of their patients, subject to infection prevention and control measures, and also to the reduced operation hours or number of patients being seen in their clinics. So I think it can resume right now on face-to-face contact, but this would be the new normal, wherein doctors still have to wear face masks when during the consult of the women for prenatal care. Ma'am Zenny, for added info, back to you.
Yeah. Um, I'm actually using my cell phone now. I have opened two gadgets. One is my desktop, and I don't think my desktop has a microphone. So can you hear me?
Yes, ma'am. Loud and clear. Please
Okay.
proceed.
Okay. So as I stated in the chat wall, we issued the department circular on continuous provision of maternal and child health services even during the pandemic. And therefore, I would imagine that in many areas, especially in the provinces, the services are continuing at the health center. And that's what the report I'm getting as well from the regional coordinators. But I also acknowledge the fact that at the NCR and maybe Region 4A, we have some problems because we were under community quarantine. And there were difficulty indeed looking for public transport. So our advisory was that if they cannot come to the health facility for the prenatal care services, then they'll have to coordinate it with the health centers, with lying-ins at the primary level, so that they can be given advice on what to do. Meanwhile, that we are on community quarantine at that time, and that was March. Okay. So I think that was just it. And then a quick survey with the regional coordinators done in the early part of April. We asked how many exactly were giving birth at home, because we noted that indeed there were reports that some women are afraid or scared to go to the health facility to give birth because they're so afraid of COVID. And the data that we got is that it was just 6% of the women who gave birth from January to April of 2020, they gave birth at home, and majority still gave birth in the facility. Although at least even NCR reported only a 2% home birth during the period, and that's from January to April. But the report of Dr. Mike Singh, I think they were also correct. There were indeed women who have problems getting into the facility because there was no transport. They were, I've seen in the news, the news where a woman who is about to deliver was still subjected to checkpoints, checkpoints procedure. And then there was this one woman who was denied admission in at least 6 hospitals, but they were, of course, private hospitals. Those are real stories, and we try to address them as well.
Ms. Zenny, are you experiencing at the DOH, what about telemedicine? Because Revi Tindugan is asking, is telemedicine sufficient for a prenatal checkup?
Well, actually, that's an issue that I have discussed with POGS, because right now we're preparing a DM. This is also an interim guideline on the repatriated OFWs are pregnant, and even overseas Filipinos are coming home and are pregnant. And we're thinking of telemedicine, and they said that they're considering that, although at one point there was a discussion about difficulty also accessing doctors via the platform. But I guess most of the hospitals have the platform. I don't know how efficient is that, but right now I have not experienced telemedicine yet.
Okay, I'll pick up on that, ma'am, and maybe I'll ask another panelist, because I'm looking now at the most top voted question. So an anonymous attendee is asking, some hospitals are already requiring pregnant women to undergo COVID-19 testing as their standard operating procedure or protocol prior to delivery in the institution. But how about those mothers who are going to, please stand by. How about those mothers who are going to deliver in the rural health units with no or limited COVID testing capability? Is there an existing protocol or guideline with regards to testing pregnant women prior to delivery? This actually sounds like something, Ms. Zenny, that you can still answer. Do you have comments, quick comments on that? And then we'll pass on probably to our other colleagues. Ma'am, please unmute. Sorry, please unmute.
Unmute. Okay. Okay, I'm using my phone. Okay. Well, the issue of having all the pregnant women tested was discussed in the DOH, but right now we don't have a policy on this. I think even FOGS have not issued any statement yet about having all of the pregnant tested on COVID. Although if allowed, my recommendation, of course, this is also from FOGS, is that we test them around the 36 weeks to 38 weeks of pregnancy, because that is when they're about to deliver. But right now we don't have that yet, except when the woman is manifesting signs and symptoms. So that's still the general guideline for testing COVID in the DOH so far.
All right.
That's just it.
Still under discussion, ma'am. So thus far, it's still being discussed.
Yes, it's still being discussed, but I don't know if it will come anytime soon. That we will allow the pregnant to be tested. I mean, all of them. Not yet for now.
Thank you, ma'am. I'll connect that to a comment. I'm seeing a comment or a question from Dr. Rita May Angbon, who is asking, in the latest DOH DM 2020-0258, pregnant women are included in subgroup F. So I'm just going to mention this. Well, actually, Dr. Angbon's question is who's going to pay for their RT-PCR swab test. But so we can't answer the question directly, but I'll redirect, Ma'am Zenny, for now the question perhaps to either Dr. Yella or Dr. Gary. In the guidance of WHO thus far, is it routine to test pregnant patients? Is there already guidance from the evidence internationally we have thus far, or is it still something under like discussion also? Ma'am Yala, Dr. Yala, or Dr. Gary? Doc Yala, is there any pronouncement on testing as far as pregnant women are concerned?
In the guidelines, there's no pronouncement for asymptomatic pregnant women because, as I said earlier in the lecture, there's no evidence that pregnant women, so pregnancy in and of itself, is associated with a higher risk of COVID-19 infection or a more severe illness if they get COVID-19.
All right, well noted. Gary?
Albert, in addition to that, I also saw the question about doing chest x-rays in asymptomatic pregnant women. Yeah, WHO does make a recommendation to not do chest imaging as part of the diagnostic workup in asymptomatic patients. If you have a symptomatic patient and you don't have proper testing, either it doesn't come fast enough, the results come fast enough, or it's not available, then you can consider chest imaging, but not in asymptomatic patients.
Right. So Dr. Gary was responding to this question that says some doctors require OB patients to have a chest X-ray with abdominal shield as clearance. So as Dr. Gary already mentioned, in asymptomatic pregnant patients, no, it's not an indication as far as the guidelines thus far are concerned. Okay, another question from an anonymous attendee. COVID positive mothers are usually admitted to COVID wards in a cohort. Do you recommend a separate breastfeeding area to reduce the neonate's risk of contracting the infection if breastfeeding will happen in a COVID ward? Dr. Yella, what say you on this?
If what is recommended is for the mother and the newborn to stay together and to observe the infection prevention and control measures. So in a ward where there are several patients with COVID-19 in one space and there's no, you can't put them in individual rooms that are well ventilated, then the recommendation is at the minimum to have the beds several, at least 2 meters apart, and to ensure that there's adequate ventilation in the room, and to observe the infection prevention and control measures, meaning respiratory hygiene, hand washing, etc., for mothers and newborns. So in terms of a separate space to to breastfeed, a breastfeeding area, it is not explicitly stated in the WHO guidelines.
All right. So, Dr. Yella, there are three questions I'm going to ask now. They're all related. In addition to you, the other panelists, just let me know if you'd like to answer. Maybe Dr. Anthony, you're the other pediatrician on the on the cohort right now, and this is actually a question for the pediatricians. Okay. First question: is there a recommendation to test a newborn to a mother confirmed with COVID-19? Okay, that's the first question. The second question is, can an asymptomatic COVID positive newborn transmit infection through incessant crying? And then the third question, which is somewhat related, Imelda Luna is asking, can you comment on the risk of healthcare workers making rounds on babies roomed in with suspect probable COVID positive mothers? What are the risks of healthcare workers doing the full EINC in the delivery room? So maybe let's do it starting from the delivery room, Doc Yala and the colleagues. So the mother delivering, what's the risk to the health workers inside the delivery room? To the ward, what's the risk to those who are attending or rounding on the babies? And then should we test the newborn? And will a crying newborn actually spread COVID over? Doc Yala, would you like to start? Sorry for the spotlight. And then I'll ask Doc Anthony.
I don't see, I don't have information on the baseline risk, but in terms of the delivery room, what we have evidence on is the reduction of the risk with the use of the proper set of PPE and, following all the precautions in that setting. The second also, that answer also applies to the next question, which is what is the risk of of health workers when they round on mothers who just delivered with COVID-19 as well as their infants? So I suppose the answer to that is that the risk is reduced with the appropriate the use of the appropriate PPE and compliance with the protocol on the proper use of PPEs. And then the question about whether newborns should be tested. If a mother is confirmed COVID positive and has the baby with her, then I think that fulfills the criterion of being a close contact of a confirmed COVID positive patient. So so depending on the availability of testing, then the newborn can be tested if that newborn is considered a close contact of a confirmed COVID-19 patient. And as to the incessantly crying newborn, well, the droplet is released by coughing and sneezing and talking. And I suppose if you're talking theoretically, then it is a theoretical possibility that with incessant crying, there's going to be a release of oral fluids or droplets from a baby.
All right, I see Dr. Anthony Calibo of DOH nodding in agreement. Doc Anthony, what can you add to what Doc Yala said?
Thank you, Dr. Albert. And of course, thank you, Dr. Yala, for starting the preliminaries in answering those sets of questions. I agree that in terms of the importance of personal protective equipment, foremost is the main reason that we have to look into and not looking directly on just the transmission of the disease. If health workers are properly protected and infection prevention and control measures are well observed, then the risk of transmission from patients going to the health worker are actually known to be effective in reducing the risk of getting COVID-19 from this. Also, if the newborn is born to a mother who is COVID-19 positive, and the question is, do we test them? Again, it's based on availability of the test. But while waiting for the availability, or the test result, this should not be a barrier for pediatricians, midwives, or nurses, or other physicians to start the life-saving effect of breastfeeding initiation. And that is why I think ever since there was a fear that I do not know what is the status of the woman who is lying on the delivery table, and is the woman going to infect me despite the fact that you're already wearing personal protective equipment. So we were on that fear perspective, even though we are already wearing full gear, and this has resulted to unnecessary separation of the newborn, and babies are deprived of the life-saving effect of breastfeeding initiation, or the EINC, or unang yakap. Now, in roomed-in mothers and babies, if you have a mother who is wearing full, a good-fitting mask while roomed in, uh, the health worker should also be protecting himself or herself when checking on the patient or doing his or her rounds, examining the baby if he or she is a pediatrician, or examining the mother if he or she is an obstetrician. So I think that's the basic premise that we have to understand. We need to continue what has been the established standard of care for mothers and newborns prior to COVID-19. And COVID-19 does not make us develop amnesia to the standards of care that we have been trained already before. We do not erase all of these evidences that they have saved many lives of mothers and newborns just because there is COVID-19. No? It's common sense that when we wear proper PPE, then we no longer, we reduce the risk of acquiring the infection. That's the one of those things. No, should I not anymore wash my hands because I am already wearing gloves? No, so that's sometimes one of the misconceptions on people. Then I tell them, if you keep on wearing that glove and you don't replace it, no, and you accidentally wipe your face with that glove that you haven't been replacing, then you also have the same risk of getting that SARS-CoV-2 virus. No? Whereas if you're not wearing gloves and you are strictly washing your hands, no, then the risk of getting COVID-19 is actually being reduced as well. So I think that's the take-home message. We need to continue the standards of care with strict IPC measures.
Right. I'll pick up on that, Dr. Anthony. So you mentioned IPC, so infection prevention and control, and PPEs. This next question I'd like to ask to Dr. Gary Kuniyoshi. So Gary, an anonymous attendee is asking, should mothers in labor wear face masks even if they are having difficulty breathing with the masks on? So there's a mother about to deliver. Should the mother wear a face mask? And would the use of a nasal cannula be contraindicated, or would the removal of the mask be also contraindicated? So this is a mother in labor. Is there anything in the guidance there, Gary, or about the use of a face mask and the use of a nasal cannula, oxygen support?
So what the guidance speaks to is the oxygen titration goal. For mothers, it's a little bit higher actually than for pregnant women. It is higher. You reach for 92 to 95%. So it does speak to the titration goals, and you need higher oxygenation in pregnant women. In regards to wearing the mask if they're having difficulty breathing, it doesn't restrict putting them on supplemental oxygen if they're having the sense of difficulty breathing, but it doesn't speak specifically to not needing to wear the mask in that kind of situation. I would think that if the mother's having difficulty breathing, then if the mask is contributing to that, then the mask should probably be removed. But it doesn't speak, as far as I know, it doesn't speak specifically to that.
Okay, fair enough. All right. So this next question is, next two questions I would like to ask from Dr. Mike Singh of UNFPA. So the first question from Revi Tindugan is this. What is the required or what are the required PPEs for health workers? Oops, sorry, it moved. What are the required PPEs for health workers providing family planning services in small clinics? Do they have to use isolation gowns? That's the first question. And Dr. Mike, the second question is, do you have reports on sexual and reproductive health concerns, particularly for repatriate OFWs and returning overseas Filipinos? Over to you, Doc Mike.
Okay, thank you, Albert. As Zenny has mentioned earlier, we are working with the Department of Health in understanding better the SRH issues of the repatriates. One issue that we are working with them on is the number of pregnant women who are repatriates and who are stuck because there is a delay in their quarantine and in their returning home to their individual provinces. But this is work in progress together with the Department of Foreign Affairs. And once we have a summary of the issues, sharing it with the different stakeholders. But as of now, it is the pregnant women which is the main issue of the rates on sexual and reproductive health. Now, what PPE is to wear in a small clinic, maybe in a small barrio, really depends on the context. Number one, as we all know, we all want all our health workers to be fully clothed with what available PPE is there. But we have to understand as well the global supply of personal protective equipment. Now, what is the risk of infection in your particular community? What is the level of transmission? What is the level of community transmission in your areas? Now, the basic PPE that we could recommend for a small clinic where community transmission is quite low would be the usual, which would be the medical masks. And to couple that with infection prevention and control, as mentioned by Dr. Anthony, such as hand washing, hand hygiene, and the physical distancing. But in instances where you have a high community transmission of COVID-19, and it's very difficult to ascertain whether those coming into your clinic are could be infected or could be carriers, then it would be recommended to have other forms of personal protective equipment. But that should be in line with what is in the guidance of the Department of Health on the rational use of personal protective equipment. Now, if there will be some specifics on this, I'll advise Rebi, please get in touch with me further. Over to you, Dr. Albert.
Thank you, Doc Mike. This next one, okay, so the time first is 12:02. I'm mindful of the time, and but this is a very rich discussion going on. So if all the panelists are okay, can we extend to just 12:10? So just a few minutes, all right? I'm seeing nods. And also, I'm getting a virtual nod from 283 attendees who are still with us, even at this third minute after 12. So I'll get straight to the questions. Nishi Castillo is asking, do we have guidelines or protocols for vaccinating COVID positive infants and mothers? Maybe I'll start with the infants. Dr. Yala, as a pediatrician and also from the guidelines of WHO, what can you say about vaccination for infants?
Well, at present, there are no guidelines yet on vaccination of infants with COVID-19. But if we will stick with the standard routine immunization guidelines, then as long as an infant is not severely ill, then there's no contraindication for routine immunization. But I believe that the guidelines are being drafted at this time. So I think it's best that we let's wait for the guidelines. But maybe Dr. Calibo can supplement that answer.
Doc Anthony?
Thank you, Dr. Yela. Dr. Albert, for example, if the child was born in a health facility and the child was born to a COVID positive mother, the child has to still receive the required birth dose for hepatitis B and BCG vaccination. So that's the rule. It's part of PhilHealth newborn package, and it's part of standard of care to the newborn. Now, the mother should also wait for recovering her health as a COVID positive patient. And I think it warrants that she returns to her physician or consult her physician as to her health status because this will also be needed as part of the health declaration when she will bring her child to her infant's caregiver to provide the scheduled vaccination because this is also in anticipation of the risk that the health worker will be encountering in interacting with the mother who was once COVID positive. No? And of course, the infant is also assessed in terms of well-being. Is the infant manifesting any respiratory illness, etc.? And that's part of the pre-assessment that is happening right now in many practitioners. Should the pre-scheduled vaccination assessment prove that the mother has no more symptoms and has completed the 14-day period to observe further what's going on with her health, no? Then the scheduled vaccination may proceed as prescribed by the National Immunization Program, and of course, following also the vaccination guidelines of professional organizations. Thank you, Dr. Albert.
So picking up from what Dr. Anthony said, I'm getting this general theme of the answer that because we are proceeding into uncharted waters, we are relying on existing guidelines in so far as the Philippines is concerned, at least. And then we're like supplementing them as we go along and we get new evidence. So I'll bring the question back to Dr. Gary, coming from the international perspective. Is there any data or are there any studies that have looked at the vaccination of COVID-19 patients, whether these are children or adults? Maybe if there's any anything from the guidance that says on that, Gary?
As far as I'm aware right now, there's no specific guidance on doing anything different in regards to vaccinations in COVID-19 patients, either adult or children. Over.
Right. Okay. So now we're going to do a little deep dive again. I'm seeing Ms. Zenny in the center of my screen. And the question of Richie and Isilio is for Ms. Zenny. It was mentioned by Ms. Zenny that the incident on pregnant women not being accepted in some health facilities, particularly hospitals. What measures are the authorities in the Philippines doing? Oops, sorry, the question moved. Yeah, okay. What are authorities doing to make sure that pregnant women will be prioritized considering the challenges of COVID-19 in these health facilities? For example, surge capacity problems, possibilities of infection. So from a programmatic perspective, what's the guidance from the DOH Philippines on the acceptance of pregnant women? Ms. Zenny? Please unmute, Ms. Zenny. Please unmute.
Okay. Well, relative to that, I think it was reiterated by our Undersecretary Vergeri that there's in fact a policy that we should not be denying women who wanted to be admitted in a hospital to give birth. And then just very recently, I think two days ago, there was a query sent to me via email, and this is coming from Philippine Hospital Association, and is asking whether we have a protocol for managing pregnant who have been positive but is now recovered. And I noted that the complaint came from a husband of a pregnant woman who is also about to deliver, and they would want to give birth in a facility, in a hospital. And this hospital has again said no to the woman because she was a previously COVID positive patient. And then I searched. We actually have a law that this is Republic Act 8344 that says anyone who is on an emergency situation should not be denied admission in a hospital. And a pregnant woman who is about to deliver is actually an emergency situation, right? So I gave this I gave a copy of the law, which is Republic Act 8344, to PHA. So that's the issue here. And then another one is that when a patient is denied admission, it is not actually a safe motherhood program. It is not just a safe motherhood program issue, but it is also a concern of regulation. So we also called the attention of our Health Facility Standards and Regulation Bureau to also look into this. And I know that they have investigated the hospitals who were found guilty of, who were in the news, and they're guilty of denying women admission. So that
All
was
right.
just, yeah.
Yes. Okay. So thanks, Ms. Zenny. So actually, Ms. Zenny's response is a very good example. Remember, the topic of our webinar series is implementing WHO COVID-19 clinical management guidelines. So the way it works is WHO and the UN family, including UNICEF and UNFPA, relies on best available evidence out there internationally from whatever country is able to generate it. We look at the weight of the evidence. It is presented in an objective fashion. And then the burden of implementation, which is really the difficult part, falls upon the Ministry of Health or the Department of Health here in the Philippines. And we're seeing that the DOH of the Philippines is doing its best to adapt to the situation, given the rapid progress. You notice that the discussion has always been, Dr. Anthony and Ms. Zenny will say that was March, which is a few months ago, and then we're now in June, and we don't know, maybe in the next month or even in the next week, something new comes out. I'd like to point out that part of this webinar series, and connected to the answer of Ms. Zenny, was about when to declare a patient as recovered. The DOH already updated its guidelines following also WHO recommendations that an RT-PCR test is no longer required to declare recovery. So long as you have 10, in the WHO, 10 days from symptom onset plus 3 days of symptom-free findings. And then in the DOH Philippines, it's actually more stringent, 14 days from the date of onset, plus clearance of a medical doctor, and also that 3-day window. I'm mentioning this because I'm looking at a comment from Richie and Isilio that says, just a thought, the guidelines mentioned and discussed are very relevant and informative for those working for maternal and child health amidst the COVID-19 pandemic. Richie thinks that the challenge is how to really cascade this information from the national level down to local governments. This information, data, and guidelines will be much helpful to guide our service providers on the ground who actually face these challenges. We need to strive to really inform them on all of what we are discussing. And actually, that's my segue to point out the time. This is already 12:12. All of our webinars are recorded. The footage is on YouTube and the WHO Philippines YouTube channel, which we also send out as a link at the end of the day, typically around 5 p.m. onwards. Also, all of the slides are made available. So we do have copies of the slides presented by Dr. Yella and Dr. Mike Singh. So they will be sent out as PDFs, together with a link to all other slides these previous days and all footage. I see a number of questions that remain unanswered, around 23, and we thank all the participants, still 251 strong at 12:13 in the afternoon. It's really a nod rather to the pertinence of these topics and how important it is to implement something which comes from international guidelines, adapted by the Department of Health, and done on the ground, hopefully, as we provide services to mothers, babies, and all other patients here. So maybe just some final words. I'll ask Dr. Gary to give a quick reaction on behalf of the WHO to what we've heard this morning. Dr. Gary?
Yeah, thank you, Albert. I want to thank Dr. Castillo for a very clear presentation. I learned a lot. Also, Dr. Singh, the very pertinent information that you had on the fly there. Dr. Calibo and Ms. Residoro, thank you for your very good answers to these hard questions. Also, the participants, all of you for your time this last week. I really see this as increasing capacity in whatever country that you're in right now, increasing your knowledge, spending your time with us. Especially with contributing your insightful questions. So I want to thank everyone for joining this whole week. Over.
Right. And I'll pass it on to Dr. Yella from UNICEF. Any final messages?
I just wanted to thank you very much for inviting the UN family here. I just wanted to stick to the key messages that women with COVID-19, regardless of the type of infection and whether they're in isolation, they have the right to respectful, skilled care, and that women and babies should not be separated because the evidence is strong to keep them together and to enable mothers to breastfeed their babies. And we hope that is informed in practice as well as in policy. Thank you.
Thank you, Dr. Yella. Dr. Mike Singh from UNFPA. Final messages, sir.
Thank you for inviting UNFPA to this forum, and thank you to all the participants. I would like to encourage everybody that even during the pandemic, women and girls have unique needs which needs to be addressed. And I look forward to working with everybody in trying to address this. Salamat po.
And then Ms. Zenny Residoro from DOH, ma'am. Ma'am, unmute, please. Please unmute. Ma'am, you're on mute, please.
Okay, yeah, I'm here. Thank you so much for inviting me as one of the panelists of this webinar. And I would just like to tell everyone that DOH is also doing its best to address every issue that's cropping up with regards to Safe Motherhood Program and child health. And we are in an abnormal situation, and therefore, just bear with us. we are trying to catch up with every policy that needs to be passed and disseminated to the implementers. Thank you.
Thank you, Ms. Zenny. And the ultimate final word from Dr. Anthony Calibo, definitely not the least, but Dr. Calibo, also from the DOH, sir, final messages.
Thank you very much to WHO for inviting the Department of Health. Ma'am Zenny and I are thankful for the opportunity that both the maternal and child health programs have been included in this very important webinar for our subscribers and those who have joined us as well. We maintain that COVID-19 is still there, that makes the health system really prone to a lot of challenges. But we have to build on our communities and, of course, empowering our mothers, parents, and other caregivers that even with COVID-19, caring for the newborn and breastfeeding the newborn is doable. It's the best thing to do with strict observance of infection prevention control measures. With all of these things, we can continue making mothers and children healthy and safe, free from COVID-19. Maraming salamat po.
Thank you so much, Dr. Anthony. And that wraps up the final session and also the webinar series, the second one by WHO, ably co-presented today by our colleagues from UNICEF, UNFPA, and guests from the Department of Health Philippines. We wish all of our participants, whether frontliner or not, we're all here together facing a challenge called COVID-19. And as already mentioned, we will persevere. We will do our best to adapt to the situation. And please stay safe wherever you are. Good afternoon and good morning to wherever you are, which time zone you're in. Have a good day. Bye.